Hi, I'm Mallie Shantzfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to a live presentation and question and answer with Dr. Alexander S. Iofin. In our webinar today, we'll be exploring the basic principles and applications of the surgical operating microscope and cone beam CT. We will also look at interesting and challenging cases that may not have been successful without these two technologies. At the conclusion of this CE, participants should be able to identify the advantages of using operating surgical microscopes in endodontic practice, describe the principles of CBC technology and situations where its use is most advantageous, apply the demonstrated techniques using both technologies in order to maximize success rate in non-surgical and surgical endodontic treatment. Before we get started, I'd like to invite the viewers to use the question box in your control panel to ask any questions, and your questions will be answered at the end of the session. Also, associated with this presentation is a free CE quiz, and at the end of the webinar, again, we will email all attendees instructions on how to access the CE quiz. I'm pleased to introduce our guest for today, Dr. Alexander S. Iofin. Dr. Iofin practices endodontics full-time at Rockefeller Center in New York City and teaches part-time as an assistant clinical professor at the Department of Endodontics at Columbia University College of Dental Medicine, and he's an adjunct assistant professor at the School of Dental Medicine, University of Pennsylvania. He was recognized by the Dean of the Columbia University College of Dental Medicine for his dedicated service for the past 10 years. Dr. Iofin graduated from Rutgers University with the highest honors and received his dental degree from the Harvard School of Dental Medicine with honors. His endodontic specialty training was completed at the Department of Endodontics at New York University College of Dentistry. Currently, Dr. Iofin is a board-eligible member of the American Association of Endodontists. In addition to teaching at Columbia University Department of Endodontics, he also has lectured on modern endodontic techniques using the microscope and microendodontic instrumentation at the Greater New York Dental Meeting, the New York County Dental Society, the Rockefeller Study Club, as well as other dental clubs in the New York area. Dr. Iofin serves as president of the New York State Association of Endodontists, and he is also a former member of the board of directors of the New York County Dental Society. Dr. Iofin, we turn the webinar over to you to learn more about our topic for today.
Thank you for the kind introduction. Thank you, Zeiss, for sponsoring this event. Just a little correction, I'm the immediate past president of the New York State Association of Endodontists. The topic of today's discussion are two very important advanced technologies that we have in the field of endodontics today. We're going to talk about combining something that we've had for a number of years at our disposal, which is the operating dental microscope, as well as something that is, I guess, newer to our field, that is the cone beam CT technology. In my opinion, these two technologies really go hand in hand. If they complete each other, if you will, and we're going to look at how we use these technologies, how we accomplish things that we need to accomplish using them, and we'll look at some clinical cases, which I think is going to be interesting. But before we talk about the present and the future, it's always good to look back. We have to see where we came from. And the reality is that the field of endodontics has been around for many decades, but not a lot of things changed for a long time. So what you were taught in the, let's say, residency program in dental school, what you practiced in the private practice was pretty much the same, and really left a lot to be desired. So the instrumentation, the obturation, this is what we typically saw, and of course, as a result, lots of failures. Not surprising. I mean, look at some of these cases. It's as if a bomb went off inside of this tooth. There's no appreciation for canal anatomy, for tooth integrity, absolutely no concept of length control. I mean, where is this got a aperture? Maybe tickling somebody's ear. And the scary part is that still we have patients show up, and I'm sure you've all had this experience, and tell you that they recently had root canal treatment completed. And this is what you see. These are done by US trained dentists in this country. in the last few years. It's hard to comprehend, but it's real. This one is a real kicker. When I saw this one, I thought this was Photoshop until somebody sent me this picture. So it happens, unfortunately. But as an endodontist, every day I'm facing these types of situations where I have to make a decision. We all have to make these decisions. What do? We have many tools at our disposal, and we have to make the best decision in the best interest of the patient. What are you going to do? Are you going to retreat? Are you going to do surgery? Are you going to extract? So we have to make these decisions together with the patient using all the tools we have. And endodontics is quite different than what it used to be, right? This is not one modality, just root canal treatment. You do root canal with a K-file or even a rotary instrument all day long. It's a triad. So we're combining the conventional treatment, non-surgical retreatment, and the key's surgical retreatment. If you're not trained in one of these, specifically, let's say surgical retreatment, you're missing out. You cannot provide the best possible care to the patient. So our goal is, of course, to save teeth. That's what we want to do. And using all these modalities, we're extremely successful at doing that. Of course, there are situations where you cannot save the tooth, and then the dental implant becomes the next best option, but only when you cannot save the tooth, when you exhausted all of these tools in your armamentarium. So it is very disturbing when you see cases like these. You know you can save these teeth. What happened? Were these people misinformed? Well, we definitely have to educate and show what we can do. Was this ill intent? And that is very sad. I would say this is criminal. And I don't want to veer off topic, but I think it's a key issue, which is going to take a couple of minutes to address this. We know that over the last couple of decades, there's been a lot of implant abuse. And industry support, financial support speaks much louder than our voices and our protests and our common sense. So it is very powerful when you see the probably the most respected leaders in the field of perio and implants publish in the most respected journals talking about trying to save teeth. And this is an editorial based on a Swedish study showing that 45% of patients after receiving implants 9 years prior developed peri-implantitis, and almost 15% developed severe peri-implantitis. And the most prolific authors are not talking about the next greatest implant design. Again, they talk about implant disease. Again, we're saying that the pendulum has swung way too far. So we have to use common sense, and the key is to try to preserve teeth. And even the gurus who were against saving teeth, definitely against giving them a second chance, are starting to say, wait a second, we got to try to retain natural teeth. So that's very interesting. But let's look at where we are. Let's discuss what were the most significant changes, advancements in the field of endodontics that helped us propel where we are now. And really, they started in about 1990s. And the first, maybe most powerful change was the introduction of the dental operating microscope. Then came several generations of rotary instruments. We got the apex locator, right? So with precise length control, no more guessing on a regular film where we are in 2 dimensions. Ultrasonic instruments in non-surgical, and definitely the key in surgical endodontic treatment. Various systems for vertical condensation. And of course, this wonderful material called MTA, the mineral trioxide aggregate, that gave us a lot of options we never had before. And of course, we have a few newer additions. Probably the newest generation of 3-dimensional shapers, shaper and finisher from Brasler, 3-dimensional cleaning. The new generation of bioceramic material, which is in the same family as MTA, but with much better physical properties. And last but not least is the cone beam CT. So we'll talk about the first and the last, the microscope and the CT, and how they combine. I've been in private practice for about 17 years now, so I can say I have experience in many different procedures. We'll talk about experience, but I'm sure you all have met people who say, why do I need all of these things? I'm experienced enough. I've tried all. I've been doing the same thing for many years. It works for me. Never have a failure, right? So it's important to stop and think and remember that sometimes experience is simply carrying out the same mistake over and over again with increased confidence. Okay, so based on all of these changes and new additions to our field, we can say that the way we practice endodontics has changed fundamentally. We have new materials, we have new instruments, we have new techniques, and because of that, we're much more successful. Our treatments are much more predictable, and our patients are much more comfortable. So we're talking about different pieces of the puzzle that fit together to make all of this possible. And as we said, the first piece of that puzzle, the cornerstone maybe, is the operating microscope. Let's look at the history. Dentistry definitely wasn't the first field to start using the microscope. ENTs were using microscopes in 1950s. Neurosurgery, 1960s. Look at how sophisticated this looks. Ophthalmology, eye surgery, 1960s. Vascular surgeons in 1970s. And really not until 1990s in the field of, in dentistry in general. Actually 1992 probably is the key date. And if some of you may recognize this person, this is Dr. Singa Kim, who I've had the privilege to practice with for the last 17 years. And he wasn't the first one to start using the dental microscope, but he is credited with being the first one to introduce it in teaching institution. So when he left Columbia in 1992 to come to Penn and build the first microscopic training center, that's when it took off. His experience in animal experiments, because he had PhD and worked on a lot of animals using microscope, and then seeing the clinical applications, that's how it happened. And starting in 92, it took off. And because of that, in 1998, every endodontic program in the US had to train their residents in non-surgical and surgical use of microscope. So what is so great about the microscope? Do we really need the microscope, and is it worth the investment? Because it is an investment. Well, it is this powerful combination of magnification and illumination. So your eye and the camera pretty much form one unit. There are different microscopes on the market, and you can try different ones, see which ones you like the most, of course. They will have different features. Probably one of the main things is how clear is the image. That has to do with the lens, the optics, the quality of the lens. In my experience, Zeiss has the best lens on the market. Again, you can try and compare and see for yourself. Now, different lines will have different features again. So let's say if you talk about the mainstream microscope, this is Xtera 300, and I've had this microscope for the last, I want to say maybe a year and a half. So it's a very nice microscope. It's an upgrade or maybe a replacement of the Pico microscope. And the way you zoom in on the, I want to say basically mainstream microscope is you have to adjust the knob. You click, you go from 4 to 10, 12, 20, right? On a high-end microscope like this Pro Ergo, you basically press a button. You have a continuous zoom. You can zoom in and zoom out. You have very finite adjustment, which is very nice. And if you're doing a lot of surgery, that is very helpful. You have something called magnetic clutch, where basically you press a button, you can move this in any direction, release the button, it locks in place. In most other microscopes, you have to loosen the knob to move, to adjust, and then tighten the knob again. The light source is very important. Initially, microscopes had halogen lighting, and halogen lighting is yellow lighting. It's really not good for visualizing any anatomical structures. Should not be used at this point. So most mainstream microscopes have LED lighting, and high-end microscopes have xenon lighting. Working distance is important. We're all different height, so whether you're 5'5" or 6'2", when you try to use the microscope, you don't want to adjust to the microscope. You want the microscope to adjust to you. And actually, what I like about this microscope, and I know some other companies are doing similar, is that you can adjust the working distance from about 200 to over 400 millimeters. So you adjust it to your height. And other ergonomics are important. Sometimes you can have a foldable tube where you can extend towards yourself, so you can angle the microscope in different ways. You have different filters for different modalities in this microscope. So the companies that invest in R&D, of course, will have more features available. Well, having a microscope is one thing. Knowing how to use the microscope is another. And you can have different approaches. I used to use high-powered loops with a light for parts of the procedure in microscope when I need it in non-surgical treatment. Surgical treatment is pretty much all microscope. But now, because of the situation we're in with COVID, I find myself that I'm forced to use the microscope for pretty much beginning to the end. And I like it. I think I'm going to stick with it. And I've seen people using some sophisticated shields. We're using plastic sheet, and we're trying actually to use it on both sides now to protect from aerosol spread. So when do we use the microscope? I guess the main reasons are identification of canals, detecting fractures, that's a non-surgical treatment, and of course, in microsurgery, it's a must. Let's talk about identification of canals. This is a nice case put together by Dr. Frankie Maggiore, who is a Penn undergraduate practicing in Germany. He's demonstrating this is tooth number 14. You can see this large restoration. He removed the restoration. Looks like curved roots, maybe some calcification there. This is the tooth under the rubber dam, ready to proceed. Okay, at this point, we're looking at 4 times magnification. So this is the lowest microscope magnification, and so on the higher end of the loops magnification. So 3 canals located, instrumented, ready to fill. Well, not so fast. Let's take a look under the microscope. Let's zoom in. Let's click 10 times magnification. Does this look right? Something doesn't quite look right on the pulpal floor. Let's go further. Let's look at 14 times magnification. Really, the color is not what it should be. Something is going on there, right? And if you look at 24 times magnification, then you can really see it. This is all calcific tissue on the pulpal floor that has not been removed. So you use your ultrasonics, maybe slow speed burrs, Mons burrs. You peel it off. What do you see in a vital case? You'll see vital tissue. This is the reason you'll have sensitivity in a lot of these cases. And of course, in necrotic cases, you'll have necrotic tissue hiding behind, leading to failure. So you remove all of this calcification. There's a pulp stone right there. Okay, got to get rid of that. And once you clean and irrigate, you start seeing these developmental lines. So a little more tissue to remove. And once you do that, you start looking for a 4th canal, right? Here you go. There it is, 4th canal, located, instrumented. Now you're ready to fill. Beautifully done case. Okay. So the point of this is to show that you cannot treat what you cannot see, right? We all know that saying, going from naked eye to loops, maybe with a light, to microscope, huge difference. It's no comparison. Okay. So it's interesting to look at this clinical analysis, which was done at the endo department of Penn a few years ago. This is a study done by the residents, looking at the anatomy of maxillary and mandibular molars. Look at this. Over 1,500 maxillary first molars looked at, 41% plus had a fourth canal. Maxillary second molars, 28%. Mandibular first molars, again, almost half had the fourth canal. Mandibular second molars, 24%. And this is something done by dental residents and the residents, not seasoned clinicians. So you may even get higher percentage. So the bottom line is finding a fourth canal is no longer something miraculous, right? You don't parade around clinics showing everybody an X-ray found a fourth canal. If you don't find a fourth canal, then fellow residents look at you funny, right? So you expect it's not an exception to the rule, let's say. Fractures, that's another important application of the microscope. We use a stain, a dye, methylene blue, to highlight anatomic structures and definitely to look for fractures. Okay, so using the microscope, we can locate the fractures. But of course, the raison d'etre for the microscope, microsurgery, couldn't exist without it. From visualizing the root, distinguishing the root from the bone, visualizing the lesion, degranulating the lesion, doing ultrasonic instrumentation, filling, retrofilling, right? All of this has to be done under the microscope. So microsurgery, again, that's a very important statement, is an integral and important part of modern endodontic practice. But we still get failures. When everything is done right, we still get failures. Why is that? Of course, that has to do with the anatomy of the tooth many times. You have an oval canal, right? Round filling, round instruments. If you use older cements that shrink, that's what you get. You get gaps. And this is exactly what we can see during the surgery at high-powered microscope. We stain these structures, and this is isthmus, right? This is the connection between two canals, which will almost inevitably lead to failure in necrotic cases. So we have to take care of this, and the only way to do it is using the microscope and, of course, the ultrasonic instrumentation. So oval canals really are the majority. It's not an exception. And it's very interesting to look at this micro CT, and it's amazing that we achieve the success rate that we do looking at this anatomy. It is quite something. So just to summarize this first part, microscope is an absolutely essential tool in endodontics. If you're doing root canal treatment, doing any type of endodontic treatment, really you should be using the microscope. And I know periodontists are trying to use the microscope, some restorative dentists are trying to use the microscope, but of course it's not universal. For us, it's a must. Okay, good. So let's switch gears and talk about a newer edition. Okay, let's talk about the cone beam computed tomography, CBCT. So most people, most patients, most everybody is aware of medical CT, even if they don't know how to use it or how it works, I should say. The cone beam CT has this novelty factor, and actually in this current climate, we have to do this. Everybody has to wear a mask, both the patient and the operator, and actually the way we are taking CTs now, we are placing mask on the patient when we take the CT. I've had a cone beam CT unit in my practice for just over 7 years. When I first started researching and thinking about getting CT scanner, I thought it's a wonderful technology, it looks very cool. We'll probably use it for some difficult cases. And as we started practicing and using it, our philosophy has evolved, and we realized how much information we're missing, how much information we're getting by having the cone beam CT in most cases. Frankly, I feel like somebody handed me a key to a door, a magic door, and I can open it and I have access to all these secrets that were hidden behind. And now I'm privileged to. And I hope that I will be able to show you and convince you how important the use of cone beam CT has become in our field. Let's briefly look at the history of CT. Actually, it's been around, the regular medical CT has been around for over 50 years. 1967, British electrical engineer, Sir Hounsfield, he was knighted, and he co-shared a Nobel Prize in medicine and physiology for his discovery and his work in imaging. In 1973, it was already commercialized. In 1982, first cone beam scanner, first cone beam was applied to the field of angiography, studying small blood vessels. In 1998, first dental CT was created. And in 2001, the first unit was approved by FDA for the US market. Well, how does cone beam CT compare to medical CT? Well, both have a source of radiation and a detector, and they rotate around the patient. But two key differences. In medical CT, that shape of the ray is actually fan. It's a fan shaped, as in versus cone beam. It is, as the name suggests, cone shaped. Okay. In medical CT, this will rotate around the patient as a spiral. So it will spiral around. So you'll have all of these spirals spliced together by a computer to recreate the volume. And there's some information that is always missing between these spirals. Whereas in cone beam CT, it's usually one rotation around the patient with 180 or 360 degrees. So you're not losing information. So here you can see again the source and the detector rotating around the patient. The unit of information that we get is called a voxel. We know, most of us know what a pixel is, right? We talk about computer screens or TV resolution, talk about pixels, but in 3 dimensions, this is called a voxel. It's isometric, it's the same on all sides, and that determines the resolution. When you get this, or the computer gets this grainy image first, and then it has to process to make this smooth output so we can interpret it. An important concept to remember is something called field of view. Field of view is what you see when you take the image. In endodontics, usually we look at one tooth, maybe a couple of teeth. So most of our cases need what's called a small field of view exposure. It's a localized, less than 5 centimeters. Actually, my machine takes 4 by 4. So you can see 3 or 4 teeth depending on the region of the mouth. And that usually is sufficient. Sometimes you want to take a look at the whole arch. Other times you may need to see both arches. And occasionally you may need to see the whole maxillofacial region, probably for oral surgeons, not for us. The American Association of Endodontists and the American Association of Maxillofacial Radiologists put out this joint statement in 2010, something called ALAR, which translates to as low as reasonably achievable. That's in terms of using the scan, using the exposing the patient. So they're saying it should not be used routinely for endodontic diagnosis in the absence of clinical signs and symptoms, which makes sense. we have to document everything we're doing. And the key here is we have to interpret the entire image volume. So if you expose the patient to a larger field of view, you're responsible to seeing all the structures present and making all the necessary diagnosis. So you don't want to take a larger volume than you need, okay? That's why it's great to have small field of view for most of our applications. Of course, there will be questions about exposure, about radiation. And I think you have to talk to the patient. You have to approach it with both science and a sense of humor. Actually, if you look at this schematic taken from two different sources, it's very interesting. You can actually talk about exposure in terms of the number of bananas. It sounds very funny, but actually a banana has a radioactive isotope called potassium-40. So you can measure the amount of radiation in the number of bananas consumed. Right? It will make for an entertaining conversation. So actually, if you eat a banana, you're exposed to 0.1 microsievert of radiation. 1,000 microsieverts is 1 millisievert. The background dose per day, meaning if you're out and about on a sunny day, you get about 10 microsieverts. If you fly cross country from New York to LA, you get about 40 microsieverts. Of course, as you get to larger radiation exposure, the chance of disease increases. So the chance of cancer is known to increase after about 100,000 microsieverts. 10 million microsieverts is a fatal dose. And in 1986 in Ukraine, during the Chernobyl reactor explosion, the exposure was 50 million microsieverts. So to put it in perspective for our use, when you discuss with a patient, if you have to take one digital radiograph, you're exposing them to about 1 microsievert. It's like eating 10 bananas. If you take one panoramic film, it's 10 microsieverts, similar to, again, being out and about on a sunny day. If you take a small field of view cone beam CT, that's what we routinely do, that's 50 microsieverts. If you remember, that flight from LA to New York is about 40, so very similar. So when a patient asks, how much exposure am I getting, doctor? I usually tell them, do you ever fly? And well, at least pre-COVID, the answer was, yes, I do. Okay, so if you fly from New York to LA, you get about the same exposure. Oh, okay, but you probably want to come back, so you get double. So that makes sense. So they're comfortable. They're comfortable with it. Chest X-ray, you get almost 3 times the exposure of cone beam CT. Head CT, 40 times the exposure. Okay, so not a lot of radiation, definitely some, so you have to have this discussion with the patient. Again, if you ask, do we need CBCT? That we got to talk about in detail, of course. The main 2 advantages that CBCT provide is the fact that you don't have the superimposition of anatomic structures, especially in the maxillary arch, where you have the sinus, you have the zygomatic arch blocking your view. That is removed when you take cone beam CT. And of course, there's no distortion, so you know where the structure is, the size of that structure or lesion. So these are 2 key advantages of taking cone beam CT as opposed to 2-dimensional radiographic film. Question from a lot of dentists is, of course, which one to get? And probably the right question would be which one gives the best picture. If you look at this study from 2010 in this European Journal of Radiology, this is the same tooth exposed by 10 different machines. Okay, which one would you like to see? This one, this one, this one, this one. If you look at all 10, I think you'll agree that this one gives the best image. And if you unmask, you'll realize that this is a J. Morita unit. This is what I use in my practice. when I started looking at cone beam CTs, most of the endo market was flooded by Carestream. And I was this close to getting that unit, which was a good unit. But then I saw the Morita imaging. And at the time, I had no idea that Morita is a well-known and respected name in medical radiology. I knew Morita apex locator. That's it. So once I saw this, I never looked back. That's why we acquired the Morita scanner. So let's look at how we can apply this technology in diagnostic cases. Diagnosis, right? That's the first thing we do. Patient comes with a problem. We have to decide, what is it? Is the periapical film enough? Is the clinical examination enough? Sometimes it is, but you'll realize that many times it is not. Simple case. Tooth number 13, root canal treatment done years prior. Patient has minor symptoms. Off-angle view looks pretty good, and looks pretty good, but there is a fistula. There's a sinus tract traced right there. What is the problem? What do? Do you jump into retreat? Do you do surgery? Not sure. Well, I took a cone beam CT, and this is what I saw. This is coronal view. This is the gutta percha. It's in the palatal canal. There's a buccal canal right here. Do you see it in the periapical film? I sure did not. Here, you can see it right here in the axial view. The buccal plate is destroyed. That's why there is a sinus tract. So you know exactly what it is. So I went in and retreated. This is a very angled view to show you the buccal and the palatal canals. And the lesion resolved, no problem. Good. Let's look at this case. The patient was asymptomatic, also with a fistula, and the dentist obviously looked at this. That looks like mesiobuccal, distobuccal. I filled. This is tooth number 3, of course. What is this? Something is not right in the palatal, probably needs to be retreated. So they send the patient. I took a look. This is the film with a trace. Looks like it's going to the palatal. Okay, so probably just have to retreat. Well, at that point, I knew to take preoperative cone beam CT in pretty much all of my retreatment cases. This is what I saw. Look at this axial view. This is the mesiobuccal. This is the palatal. Palatal was filled. This is the distobuccal root. What is this? Look right here in the coronal view. This is the buccal. This is the palatal. This gutta percha is through the furcation. They perforated, filled the bone. It's hard to imagine that the patient was not in pain. They were not, and they're still not in pain. And it's hard to imagine that the operator didn't know that's what was happening, but this is what we saw. I was thinking of trying to retreat actually and maybe seal the perforation and locate the distobuccal. The patient disappeared. I have no idea what happened to the tooth. Not surprised. Wouldn't be surprised if it was extracted. Look at this case. The patient is sent because of vague discomfort in the upper right. Number 2, what do you see? Looks like poorly treated root canal. Looks like a prosthetic failure. Number 3, much better than root canal treatment. Probably something going on here, hard to tell. So we'll go ahead and take a cone beam CT. So this is me manipulating the scan. If you look at the sinus, completely clouded. Look at this. This is tooth number 2. The sinus floor is destroyed by this lesion. You had no idea. Look at this. There's resorption in the mesiobuccal canal. Okay. You can see the lesion on number 3. So number 2, I think, was deemed non-restorable. This carries here as well. It was removed. Number 3 was treated. Okay. Could not see this with a periapical film. What about this case? Tooth number 14. Patient is reporting some percussion sensitivity, nothing major. Root canal treatment done years ago. Again, you can see poorly treated, large post. The crown looks good in this view. We take a scan. what do we see? This is the sinus. This is the floor of the sinus. Look at the dome-shaped floor of the sinus. This is an enormous lesion. Okay? This is what we call maxillary sinusitis of endodontic origin. This type of lesion many times will cause sinusitis, secondary sinusitis, and we try to educate ENTs because we see a lot of patients go through unnecessary surgeries, procedures, getting scoped all the time because of sinus problems when there's no really underlying sinus condition. It's all secondary to the tooth infection, usually in the maxillary first or second molar. And I tell patients, I'll treat your tooth, I'll get rid of the infection, and I will treat your sinusitis, no extra charge. They loved it. So we went ahead and retreated, pre-op, post-op, 12-month recall, and then the patient came back at 24 months, and look at the dramatic change from all this mucositis and dome-shaped floor of the sinus to this. This is pretty much complete resolution of normal anatomy. There's some rarefication here. It may or may not heal after 24 months, but the patient is asymptomatic, no sign of disease in the sinus. So that's a wonderful result that we get. What about fractures? Again, fractures are not always easy to diagnose with a cone beam CT. You have to do a clinical examination. But look at this case. Again, prosthetic failure, dislocation lesion, and probing pretty deep. Scan was taken. Right here on the axial view, you can see this is the fracture. And again, you cannot always see this. You look for certain signs. Here, it's quite clear. And what about this case? Very similar. Furcation involvement. The referring dentist was very skeptical about keeping this tooth. Wanted to extract, but he was smart enough to know at least to let me examine the patient. And we did. This is the cone beam CT. You can see the periapical radiolucencies here. You can see the furcation involvement, and I don't know if you can see this. If you magnify right here, it looks like a lateral canal. Of course, you have to look in a dark room. You have to manipulate the image, but this is what I saw. And once I saw that, I said, wait a second, I think this is the reason for the furcation breakdown. And the general dentist agreed, that the patient agreed. We started the non-surgical treatment. This is calcium hydroxide in the tooth. Look, getting pushed out into the furcus, so it gave me confidence. This is what I'm seeing. This is exactly what it is. Went ahead and completed the case. This could be the sealer or still the calcium hydroxide. I don't have follow-up on this case, but I'm pretty confident that it's going to heal very nicely. So basically, the cone beam CT is our GPS. It's a roadmap. It shows us exactly where to go. Sometimes we use it pre-operatively. Sometimes we use it in the middle of the treatment. You may be treating an anterior tooth, calcified. You cannot find the canal. You stop, you go, you take a scan. There it is, just a millimeter lingually and a millimeter mesially. Bingo, you found the canal. That's the advantage of cone beam CT technology. What about resorption? I find myself treating a lot of resorption cases. I don't know what it is, whether they are more prevalent lately. Maybe the general practitioners are more aware. Maybe it is the fact that we're looking at even two-dimensional radiographs in digital format on a large screen, so you can see much better. So here, 3 cases. Something is going on here, much more pronounced here, maybe something here, all diagnosed by general clinicians or referred for evaluation to me. So tooth number 8. Again, something doesn't look right. Sharp-eyed clinician noticed. Looks like resorption. Maybe, maybe not. Where is this lesion? We take cone beam CT. Here it is. This is the buccal. This is the palatal. Right? Small localized lesion. You can see it in the axial view. This is external invasive cervical resorption, probably class 1 Heather's classification. These are fibrovascular lesions. They're small. There's usually a lot of predentin or dentin walling off the canal, so no symptoms. Patient is completely unaware. You don't need to do root canal treatment. You go ahead and flap. Palatal is more challenging than buccal, but small lesion, no problem. Here it is, exposed, cleaned out, G-Restore placed. G-Restore is the material of choice for me for resorption repairs, just because of nice healing. And usually the PDL attaches very nicely, even to the material. Here it is, final result. What about this lesion? Looks much bigger. Again, where is this lesion? The patient has no symptoms. We take a scan. Okay, here it is, much bigger. You can see it here. You can see it here. In the axial view, it's almost touching the canal, but probably some predentin, so the patient is really not aware. Okay, so in this case, we have to do root canal treatment first. If you start doing the repair, you're going to drop into the canal and block yourself. So the patient understands root canal treatment is done first. Then you flap elevate on the buccal in this case. Here's the fibrovascular lesion I talked about. You can nicely visualize under the microscope. Cleaned out. Again, G-Restore goes in. Here's a post-op, 12-month recall. What about this case? Doesn't look as crisp, but again, caught by the general practitioner, off angle. If we take cone beam CT in this case, what you see is the lesion is actually all along the root. It's probably class 4 Heather's external invasive cervical resorption. And this lesion is really not treatable. Again, as long as the patient is asymptomatic, you don't have to do anything. You have to inform. The tooth probably will get undermined and they may fracture the tooth. Okay. So back to endodontic microsurgery. As we said, it is an integral part of modern endodontic practice. At this point, all of the surgical planning in my practice is done with cone beam CT. Pretty much no exceptions. Okay, simple case. Tooth number 8. The patient presents complaining of pain and a burning sensation, which was interesting. Burning sensation under the nose. You look at the periapical film that was sent from the referring dentist. Looks like there's calcification in this canal. Maybe something going on here. Once we take the CT, look at the size of this lesion. Huge. Look here on the axial view. This lesion is almost touching. It's approximating the nasopalatin canal. So I assume this was the reason for the burning sensation. So we went ahead and started non-surgical root canal treatment. I was able to locate the canal, but I was not able to dry it. It kept draining and draining and draining. I think we left it open for a while, no change. So had to fill the canal, some excess sealer, not worried about it because we did combined non-surgical and surgical treatment. Here, nicely documented under the microscope, raise the flap. This is a small fenestration, but once you peel this huge lesion underneath, this is the apex, stained. Ultrasonic instrumentation is done. Bioceramic seal is in place, and then in this case we used collagen, the not BioGuide, the foundation material from Brasler, sutured, and this is the post-op 31-month recall. Actually, he came back because he had another problem, so I was able to take a scan at that time. Look at the healing. Look at this lesion. Gone. These are reversed here. So you can see how close this was to the nasopalatin canal. Nice bone all around, no symptoms. No. This is an interesting case. This is a middle-aged male who was referred by his general practitioner. There's a history of trauma on this tooth number 9. years prior, the crown was replaced once. You can see it's horrendous crown. Aesthetically, it's a nightmare, but he couldn't care less. All he wants to do is save his tooth. The general practitioner suspected fracture. I suspected fracture. I said, I don't think so. Well, doctor, whatever you need to do, I'm willing to try. Okay, if you're willing to try, I'm willing to try. Well, we took a scan. Oh boy, look at this. Almost no buccal bone. Okay, buccal plate is gone. You can see it very clearly. This is what it looks like. Again, aesthetically, it's a nightmare, but he's okay with it. This is the fistula. Once I flapped, I saw something interesting. What is this? Let's magnify and stain, wash off methylene blue. It's a lateral canal on the buccal surface of the root. Right here, that's already ultrasonicated. The apex prepared as well. Right here, this is what it looks like. Sealed with bioceramic, of course, GBR, guided bone regeneration, membrane sutured, pre-op, post-op, 18-month recall. I did not see a fracture. I said that even if I didn't see it, maybe it's somewhere else. I'm not sure, but of course, once I saw the lateral canal, that gave us hope. Look at this, pre-op, 18-month recall. We went from this, no buccal bone, to this, the buccal bone actually developed right to the level of that lateral canal. So he still has the tooth in his mouth. Look at the buccal plate. It's wonderful. And actually, I had another case like this the same year. So things come in pairs, of course. We're doing on time. Okay. This is a patient who presented with pain on the lower right, tooth number 29. You'll see calcification here. Looks like there's a lesion. Again, I said, I'm not sure I can treat this. I don't see the canal whatsoever. The patient was insistent on trying non-surgical treatment. Okay, we can try. We tried, well, we took a scan first. Look at the lesion here, 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 very large. So yeah, I tried, I could not locate the canal. Of course, using microscope, no avail. So we had to do the surgical route. The patient was okay with that at that point. So this is the osteotomy. This is the canal reflection in the mirror. You can see it's oval. Obviously, it's leaking. So ultrasonic instrumentation, bioceramic seal, bone graft, bioguide sutured, and this is the final result. You can see I sort of went off course a little bit, redirected, went down quite a distance, could not find the canal. So this is sealed with a biodentin. And look at a 7-month recall. These are different sizes because also the patient needed an evaluation on the top. So we took what's called 4x8 so we could see both upper and lower in the same exposure, not expose the patient twice. So compare this to this, perfect healing. Look here, and again, the axial view, this huge lesion, all gone, just in 7 months. It's a wonderful result. This is an interesting set of slides from Penn Endo showing the upper left and upper right. Pain. Can you see anything? Not so sure. Scan is taken. Radiolucency on number 19. Huge one on number 31. Smaller one here on 30, but that was not symptomatic. So I can tell this is a Carestream machine just by these markings. And you see it's not as crisp as Morita. So if you look here, this is the buccal plate, lingual plate. You see how thin the buccal plate is here. Very easy to approach surgically. On the second molar, very thick. Good luck drilling through all of this bone. So the decision was made, root end surgery, intentional replantation, which is a wonderful technique, especially on a second molar with conical roots. So they did that, pre-op, post-op, 12-month follow-up, nice healing. pre-op, post-op, 4-month recall, nice healing. So the cone beam was, again, the GPS was the deciding factor how to approach this type of case. And let's look at this last surgical case. You know, they tell you don't treat family or friends if you don't want to lose them. I didn't have a choice. This friend called me frantically on a weeknight. She was in pain. She was swollen. She went to her general dentist, who recommended extraction based on a 2-dimensional X-ray. Sent her to an oral surgeon. He said the same. I don't have periapical film. They never sent it to me somehow. So she came to me. I said, let's see what's going on. This is tooth number 14. The history is root canal treatment done decades ago in Russia. Surgical treatment, probably traditional surgery done years later, I think in Israel, was quiet, and now all of a sudden she's in agony. So I looked at this. Well, you can see the root canal treatment was done. MB2 was missed. Let me go back for a moment. You can see the resection was done incompletely on the distal buccal root. This is part of the distal buccal root. And if you look here, the distal buccal and palatal are fused. The operator did not have, I assume, cone beam CT, maybe didn't have the microscope. They had no idea, so never resected all the way. So this is what it looks like. So again, MB2 is missed. This is that lip of distal buccal that was never removed. So I said, let's try. We're going to do a resurgery. This is the fenestration. MB and MB2 canals located. This is a nice view. This is the distal buccal on the palatal long root and the isthmus in between that we had to address. Ultrasonic instrumentation, sealed, and this is the final result. Okay, looks kind of funny here because of all of these canals, 4 canals and an isthmus basically filled. So if you look at the pre-op and 14-month recall, look at the healing. Look at this here, look at this here, mesiobuccal, MB2, distal buccal, palatal, and in this view you can see the isthmus continues all the way through. So in this case, she did not lose the tooth, I did not lose a friend, which was nice. Okay, so let's summarize. Basically, cone beam CT is a must. It's a must in non-surgical retreatment, in surgical retreatment, in deciding whether to extract or keep the tooth, let's say if you have a fracture. This is my protocol, and I think it makes perfect sense. When we started, as I said, we looked at using it in certain cases, and then we realized how much information we're missing. It's an investment. It's a financial investment. You have to train yourself. You have to train your staff. It takes time. You have to change your protocol. So is it still worth getting the cone beam CT? The simple answer is absolutely. The quality of care that you can provide to your patient is completely different. You are comfortable with your decision-making process. You know that you do the best for your patient in the best interest of the patient. The key is not to look at the scan in the back and come back and tell the patient, this is what I saw. The key is to basically review the volume together. Simple, inexpensive investment. Buy a large screen TV, put it in front of the patient in the room, shut down the lights, look together. Patients who were hesitant to even take a scan, and now they're hesitant to do any treatment, all of a sudden they see exactly what you're talking about. They see the lesion, they see the problem, and they actually ask you to take care of it. It's absolutely phenomenal. The nice thing about the Morita machine I have is that I can take a panoramic view, something called a scout, so I can locate the region and pinpoint the region I'm interested in and take a cone beam CT from that. So that panoramic film means that I don't have tunnel vision. I can see the condition of the entire mouth. I can share that panoramic film with the referring dentist. I can maybe see other issues, other problems that need to be addressed in their mouth. Sometimes other practitioners, like let's say periodontists doing implant treatment planning, will ask for a CT. So you will get patients referred to you. Basically, the machine will pay for itself. If you're able to charge a patient even a small fee, let's say you charge $100 for a scan, let's say you do 2 a day, which I think is perfectly reasonable, and I do more than that. So $200 a day, 50 weeks a year, 52, whatever. So let's say $100,000 a year generated income. I'm sorry, yes. So in 2 years, you can pay for the machine. After that, it's pure revenue. So you're doing the best treatment, you're comfortable with your decision making, and it's a moneymaker. So I think it's a win-win situation. Well, I think we looked at 2 wonderful technologies. I hope I convinced you that both are a must, both combine to really elevate the way we practice today to a different level. And I hope you follow my advice and you use both if you already don't. I thank you for your attention, and I'll be happy to answer any questions you might have.
Thank you, Dr. Iofin, for your very informative presentation. I do have some questions, but before I get to those, I would like to invite viewers to use the question box in their control panel to ask any questions that you may have. First question, what microscope do you recommend?
Okay, so from my training, my private practice, and teaching, I probably have tried every microscope available on the US market today. It's personal preference. You can try and you can see what works for you. As I said, there are different features. The optics are very important, and in my mind, Zeiss has the best product, and that's the reason I use it. So that's my recommendation. But definitely, there are other ones that are very good on the market.
Do you document all of your cases, and what camera do you use?
I document all of my surgical cases. I don't document all of my non-surgical cases, but all surgical cases are documented. What camera do I use? I have an older Zeiss microscope from Magus, which has a nice Sony mirrorless camera attached, which works very well. But the newer microscope, the Xterra, has a built-in camera and camcorder, and that is wonderful. So you just press a button. Actually, another nice thing with that microscope, I think there are different packages. If you get the I guess the more expensive package, you can use the iPad, and from the iPad you can take pictures, you can take videos, you can show the patient exactly what you documented, which is a very nice feature to have.
Okay, what are you doing if the patient refuses to take a CBCT?
Well, I mean, we have patients, it's amazing, sometimes refuse to take periapical films. You have to convince them. As I showed you the graphic, there are many different ways to approach it. But as I said, the combination of science and humor. You have to explain, you have to compare. If you take a flight, this is all it is. If they refuse to take it, they refuse to take it. Meaning there are some cases where I'll tell them, well, I'm going to be missing some information. It's in your best interest. If you don't want to take it, I can still do the work, but there are limitations. And there's some cases where I may not be comfortable doing the procedure without having the cone beam CT, certain surgical cases. So that's up to the patient. That's their ultimate decision.
Okay, and one more question we have time for. How do you manipulate the CT to rule out a fracture?
Well, fracture, as we said, is not always easy to see with a CT. I would say majority of the time you cannot see the fracture with a CT. You definitely have to have the right environment. You turn the lights down, you manipulate slice by slice, you rotate, you can change the thickness of the slice. There are many different ways, and actually it's nice. Morita has wonderful software that allows you to do a lot of things. But it starts with a clinical examination. Of course, you look for probing, and with a cone beam CT, you look for pattern of bone loss. I mean, if you have a teardrop, what we call it on a periapical film, if you see bone missing all around the root, that's usually a telltale sign of a fracture. It's not always easy to see it, but sometimes we can, and it definitely is very helpful, the combination of clinical exam and CT to determine if the tooth is fractured. Then you don't have to flap if you know for sure. Save patients, money, time, aggravation.
Okay, well, thank you to everyone for your questions, but we've run out of time today. So if we did not get to your question, we will answer it after the webinar via email. Please make sure to take the free CE quiz associated with this webinar. Shortly, we will send you a recording of this presentation and instructions on how to access the CE quiz. Again, thank you all again for attending, and a special thank you to Dr. Iofin and our sponsor for this webinar, Zeiss Meditech. Thank you and have a great day.
Thank you very much.
Thank you.